use the tool. Don't be the tool. Don't rely on those.
Don't be a tool.
Yeah.
You are the tool.
Work on your own systematic approach. And that systematic approach that you've developed, if you've developed it already, do it each and every time and don't stray from it.
Engine 23 and Medic 23, Larpenteur Avenue West and Fry Street. Police on scene. Shooting. Stand by for police. Box 546. On fire off score. Time 21:07.
Hey everyone, welcome to EMSconnect On Shift, your go-to podcast for everything EMS. Sometimes we're going to educate, sometimes we're going to review EMS articles or books, sometimes we just hang out with badass people and BS, but I'll tell you what, every time we're going to have an absolute blast. I am your host, Shaun Pitts. I'm the head of education for EMSconnect. We are a top-tier EMS education organization that offers more education than you'll ever need. We have a website with hundreds of hours of education. We got online EMS refresher courses, and we even offer on-site courses. Before we jump into this episode, please take a moment to go to whatever app you're listening to this on right now and subscribe to our show, give feedback, and give our show a rating. Every rating you give truly elevates this podcast and makes it easier for others to find us. Please help us spread the word about EMSconnect and the On Shift podcast so everyone can get educated.
Dr. Nathan Denison.
Wow.
Nathan Denison.
Don't call me doctor.
No.
Far from it. Yeah, Nathan Denison, Director of On-Site Education for EMSconnect and EMS instructor. Previous paramedic educator for a number of years. I'm also a firefighter paramedic in the lieutenant position for a local Spokane agency.
All right. Well, let's go ahead and get started with BLS medical assessment. So today's lecture is pretty generic, right? We did EMS detective already. We've done a couple other lectures targeting a couple different topics, but today is just kind of general overview of medical assessment, right?
Yep. Yeah, a lot of review stuff. Everything that we covered in your initial EMS or EMT course, of course. But it's always good to review this type of stuff, especially if you're not seeing a lot of patients out there, or maybe we can add some insight or some little pearls to take away from this lecture. So objective today, again, a lot of review, right? Our AVPU, whatever that stands for, primary patient assessment, how we're going to tackle that or how we should be tackling that. Vital signs, man, those things, they're never going to go away, right? Vitally important. Working through our head to toe exams, focused exams, and this thing called active listening. And then how we're, when we're determining transport, how we're deciding that, and what facilities we might consider. And then we're going to end, of course, with the case study, because I think it's always nice to bring one of those, kind of round out what we've discussed thus far and put it into practice for us. So AVPU. So this thing we learned back in the EMT course, right? So that's our initial phase, right? So we walk in, we are presented with a patient. We're starting to form our general impressions, that sick versus not sick thing. And one of the things that we're going to look at is what kind of neurological state they're in, right? So that AVPU is what we go on, right? So if we walk in, patients' eyes are open, they're tracking us as we walk in. That's fantastic. That's what we are always hoping for. They are alert, right? Now, are they necessarily oriented, right? Are they confused or not, right? If we're starting to look through that GCS, however conversation is going to be, we're not sure yet. But the fact that they're watching us walk in, their eyes are open, that's a good start, right? So if they're not, if their eyes are closed or they seem to be, a little dazed, can we initiate some type of response with talking to them, right? And this might have to be shouting if they appear unconscious, right? So we're starting to work through a progressive, what are our next steps after we get past this, right? So do we talk to them and then we elicit a response? Fantastic. We can move on from there, right? If we don't get any response by talking to them or shouting at them, we must have a physical action, right? So some type of painful response. I want to see, neurologically, is there anything going on up in the head that is going to cause a reaction, right? We can, and on the basic level, that is all I want, right? Just do something, because if you're truly unresponsive, like down at the bottom, if we go through that progression, we don't get any response, things are about to get crazy, right? As far as patient treatment goes. So, type of painful response, there's a lot of different ways to achieve that, right? Back in the day, it was the sternum rub, which was, very aggressive, and it did cause a lot of injuries. Nowadays, there's, other ways that we can do it. There's some pressure points. We can use a pen, place in between their fingers, squeeze, some type of cuticle reaction. Nobody likes their fingernails being messed with, or shouldn't like those being messed with. So can I do something to where I get a reaction? Usually that reaction will be that patient is pulling away from me, right? This is still a sick patient if we're getting to those painful stimuli, but there is something up there neurologically that we can work with, right? And then again, unresponsive, we're getting aggressive when we have to get aggressive, right? So,
and I think it's important to look at this AVPU. You mentioned the sick, not sick. That's also another great way of looking at this patient at the end of your AVPU.
Yeah.
Is the patient sick or not sick? The Sick or Not Sick program, written by Mike Helmbach, is, if anybody gets a chance to take a look at that or go through that, or there's podcasts that Mike has been on, resource able to read that. But that's a real good, as an EMT, I think it's a very powerful skill to be able to interject right here of determining sick or not sick. Because if they're sick, then we kind of have an algorithm-based response. And then if they're not sick, we kind of have an algorithm-based response. So as you're learning how to use this, I think that's a great set of tools to be able to use.
Yeah. All right. So then our primary patient assessment. So patient presentation, like I said, drives how we're going to be, right? So if they're alert oriented, they're work through the ABCs, they're breathing okay, they don't appear to have any foreign objects in their mouth precluding that, and visual signs of circulatory perfusion, right? So they're not pale, they're not diaphoretic, they're not gray, which would be a really bad sign, right? That kind of drives us. So are we going to go through our airway, breathing, circulation? If they're truly unconscious and they don't look like they're breathing effectively, are we feeling for a carotid pulse and going through our CAB, which would be, circulatory first, compressions, yes, and then working on airway breathing? Or are we presented with maybe a medical trauma scenario where they have massive blood coming from somewhere and we need to address that first because that is bad. If they're bleeding out, that's not good, right? So that is our initial, primary impression. Will drive everything we do with that. Excuse me. Vital signs. Okay, so up there on the screen, you see that monitor, right? So vital signs, I think we've said it before, but I'll say it 1,000 times more, are vitally important, right? How are our patients actually doing outside of what we can see, circulatory wise, respiratory wise, oxygenation wise, what's going on, right? So they must be completed and in a timely manner, right? So unless even if you're working as a single provider on a call, and you're talking to your patient, trying to gather, the history of what's going on presently, you can work through some vital signs, right? That might be as simple as feeling the radial pulse, which we talk about, in school, and we say, hey, this is a hands-on situation, right? We have to have hands on our patients, feeling them. Check a radial pulse. Does it feel fast? Does it feel slow? Can you feel it at all? Right? That'll tell us a lot, right? That's not, we want to get numerical values so that we can start trending our patient contact. But hey, if you're by yourself and that's all you can do for right now, then fantastic. That's what we go with, right? So, but as we progress through that, blood pressures, our tendency, like you see on the screen there, you have a Life Pack 15. We don't, we're not sponsored by anybody, but that's just the picture I found. But the bottom line is we have a tendency to, these things are great, right? So they can do our blood pressures for us. We have a tendency to throw that blood pressure cuff on and press NIBP, and whatever number we get, then we go with, right? No. Okay. So manual blood pressures, we talked about it in trauma assessment, must be completed. A manual blood pressure must be done so that we have a good starting point, right? The machines are great, but us as humans are better, right? Monitors have their limitations. If somebody is tensed up, it's not going to read accurately. If they're moving around, it's not going to read accurately. If it can't perceive a blood pressure at all, it's not going to read accurately. So yes, they're a good tool to have, but we have better means, right? Us. Just use your blood pressure cuff, your stethoscope, practice doing those so that you're proficient at it and get it done, right? So that's where that accuracy comes down, right? If I get a blood pressure back from my LifePak 15 and it says 226 over 147, is that accurate? I don't know. Maybe. Right? Or maybe that patient was tensed while they were doing, or, we're talking to them, trying to get, our sample OPQRST at the same time that blood pressure is taking, and they talk with their hands a lot, right? So that comes back as a potentially false reading. We should always be double checking that with a manual blood pressure. And if it does come back at 200 over one something, then okay, it's not good, but at least, we're trusting but verifying our information, right? So, so do that, right? Oxygen saturations. Yes, our monitors are fantastic at that as well, right? Using our SpO2 monitor on our or portion on our monitor rather, they're great. But again, they can be tricked as well, right? If the patient is not, if they don't have good perfusion, or maybe it's cold outside, then we're not going to get a good accurate reading. So if you're using your pulse oximeter on your monitor, put it in the mode where you can see that pleth wave, right? So if we see on our screen, this is 99%, and then, so that's a blue number, and then alongside of that is a blue wave, right? And Zoll might be a little bit different, know the equipment that you have, but it is a good wave, what we call a pleth wave, right? That means that monitor is picking up an accurate reading of oxygen saturation, and we can rely on it, right? So use that, and then know that can be tricked as well, right? So there is, if somebody is exposed to carbon monoxide, or they're a smoker, and they have history of, COPD or emphysema or any other lung disease, and it's reading at 100% with a good pleth wave, well, that could be that CO affecting as well. So take your readings and then work beyond that and understand what they're meaning, right? The heart rate's up there on top, followed by the 3 lead. If you're able to do that, fantastic. That's always a good thing to do. Do you necessarily need to know, all the ins and outs of the QRS wave and the P wave and T wave? Not necessarily, but if we put them on a monitor, say we have advanced life support coming, then that's one step that they don't have to do. And then that will give you a pretty accurate heart rate, right? So that'll help, as long as feeling the radial pulse and then putting them on the 3 lead, that'll help, right? That yellow number that we see, that's end-tidal carbon dioxide. So every time we exhale, we breathe out carbon dioxide. So that helps us in our assessment of oxygen carbon dioxide exchange. How well are they oxygenating their cells, and is there any disease process that could inhibit that, right? So again, do we necessarily at the EMT level need to know the ins and outs of end-tidal? Not necessarily. I would venture to say yes, but no. But put that on. If you have, the simple way is a nasal cannula with end-tidal CO2 capabilities, right? So it's just a nasal prong with a little cup, and every time they exhale, we see that reading. We should know at the EMT level that a normal reading is between 35 and 45 millimeters of mercury, right? Anything beyond that, just know that if it's too low, something's going on. If it's too high, something's going on, right? We need to start diving into that. And then that waveform, the yellow waveform down at the bottom, that is ideally what that end tidal waveform should look like, right? So that is a good exhalation. There's no obstructions. That is what it's supposed to look like. If we see anything else than that, then we need to start thinking about what could be going on, right?
I think as a new EMT, vitals is one of the more stressful things, right? Because we have EMTs that come to us and say, hey, on every patient, what do you want for vitals, right? And I think the term that's used a lot is baseline. So at a baseline, what do you want for vitals? Well, to me, it changes per patient, right?
Mm-hmm.
If I don't have a life pack or a monitor, then I want a manual blood pressure, I want a manual heart rate,
Mm-hmm.
and that's all I'm going to get if I don't have a monitor. If I've got a finger clip on, that I want an SpO2. If this is a respiratory patient, I'd love to have end-tidal CO2. Right. If this is a cardiac patient, I'd love to have a 3-lead. If it's going to change depending on the situation you're in. The NREMT does not consider a glucose a vital sign, but in an unconscious or altered level of consciousness patient, to me, it is vital to have that number to be able to determine, are we hypoglycemic or hyperglycemic, or are we in the relatively means of normal? You can throw temperature in there on a septic patient or an altered level of consciousness patient. To me, a temperature is something vital to have inside of this. So don't look at vital signs as I want a list of things that I'm going to get on every single patient.
Mm-hmm.
We should have those, right? But to me, that's blood pressure, heart rate, SpO2, that's, and respiratory rate, of course.
Yeah.
But use vital signs as depending on your AVPU and you're sick or not sick and your patient's chief complaint, then you can follow down a line.
Mm-hmm.
If you're an agency where your transport is right behind you, then you may not get to all these things. If you're on scene for 20, 30 minutes, waiting for a transport, or you are that transporting agency, then you might have a laundry list of things that you're able to obtain. So as a new provider, don't get intimidated by, well, I have to have all these things.
Right.
Get as many as you possibly can, document them first off, document them accurately, and then don't forget about follow-ups, right? Room air saturations before saturations on oxygen is extremely important.
Yeah.
The other one that I think that's overlooked is trending blood pressures. Not just sitting down, right? You got a patient who says they're dizzy and they don't feel good. So do orthostatic blood pressures, right? Have them take a blood pressure while they're sitting down, stand them up and assist them, and then take their blood pressure standing up. Like, don't forget that I think there's just a lot of intimidation that sits around vital signs.
Yeah. And they are vitally important, but we don't need to the best way, don't freak out about it.
Yeah.
Right. Just do it and be good at it.
It's just like we're going to get into the questioning patients, and people get caught up into sample and OPQRST and DCAB BTLS and all these acronyms and mnemonics. And realistically, just talk to your patient. What's going on today? That question alone will probably get you far more information than you ever needed to know about the 9 different things going on.
Yeah.
Why are we here? How can we help you? Right? We don't have to get caught up into these onset, provocation, quality. Those are all great tools. They're ways to get us to be better, but it's not something we have to stay within that little itty bitty sandbox of only ask these questions.
Yeah. And you mentioned the trending, and just simple form trending. We start at the base. When we make patient contact, we do that initial set of vital signs, be it blood pressure, respiratory rate, pulse, SpO2 monitoring, whatever you're doing for your patient presentation. That is our starting point. That trending that we do is merely determining, is this patient getting worse? Are they getting better with the treatments that we're doing, or are they staying the same, right? What we're doing is not working, so maybe we need to be thinking about something else, right? Differential diagnosis. We come in with a huge differential diagnosis of what could be going on with the patient, and we start trying to narrow that down so that we end with, a couple, 3 or 4, whatever. So how are their vital signs doing? How is that patient compensating with what we're providing? Are they getting better or worse? Can we start knocking some of those differential diagnoses off? All right. So moving on then, head to toe exam. Physical exam is the key word in that, right? So we have to have hands on our patient. Now, that depends on, in the medical setting, what they're complaining about. Right. So do I need to touch head down to the toes? If somebody's complaining of difficulty breathing, Not necessarily, but we need to be taking a look, right? Look at their pupils, the reaction to their pupils. Are they using a pen light, one that's not going to blind them, preferably? If we shine a light into their pupils, do we get a reaction? And how is that reaction, right? Is it slow? Is it normal? Is it not at all, right? That's important. Does it necessarily tell us what's going on with that patient right now? No, but that is an asterisk. This is important, right? Neurologically, something could be going on. Looking at their skin, we do that all the time, right? As I sit here talking to Shaun, I am evaluating his skin, and it looks somewhat blue with this lights that we have, right? But is that bad? Maybe, I don't know. But you don't have to have hands-on to do a good, thorough assessment. Just look, right? Looking at their face. Does it look like there's any obvious injuries, any obvious obstructions, any obvious swelling? Their neck. Can we notice any jugular vein distension, which is an important finding, right? If we're having a difficulty breathing, are they using accessory muscles from their neck to try and draw in air into their lungs, right? We talked about radial pulses. Pulses are great to assess. That helps us work through perfusion. Abdomen, does it look distended? And if it looks distended, ask the question, is that normal for that patient? I know, I always preface with, I'm not trying to be mean, but your stomach looks a little distended. Is this normal for you? Yes or no? And they'll tell you, yeah, yes, it is, or no, actually, it's been growing a little bit more. That's an important finding, right? And then down at the legs, right? So feeling for pedal or distal pulses again at the feet, if we need to. That tells us a lot about perfusion. And then looking at their legs, their ankles, do they look swollen? If they look swollen, do I touch it? If I touch it, does it stay pitted? What do we call pitting edema? Or doesn't do anything at all, right? It just kind of bounces back quickly, right? So that's a positive finding if we push on their skin, if around their ankles or lower legs, and that stays. We push on it, stays in that pitted, right, as our finger was. That's an important finding, right? This evidence of fluid. Man, I just lost my train of thought. Fluid retention. Thank you. And that could be evidence of some type of heart problem, which we can talk about later, right?
And those are all good habits to get into on a majority of your patients, right? Ask for permission. Hey, real quick, you're saying you're having some difficulty breathing. Mm-hmm. Okay, great. Can you describe that to me? Quality of respirations, are they equal? But then we know that difficulty breathing could be related to the cardiovascular system. So, hey, real quick, I'm going to pull up your pant legs, take a look at your ankles. Have you been noticing any, fluid retaining in your ankles or anything like that? Those are all great ways of just diving deeper into this assessment, just like the Cincinnati stroke scale. Mm-hmm. You can do a fast exam on anybody. You're sitting there and you're just killing time because the ambulance isn't there yet, or you're not ready to go outside. There's no problem of, hey, real quick, you're saying you're having some, numbness and tingling in your hands. Do me a favor, stick those hands out in front of you, turn your palms up towards the sky. Are your grips good? Push on my hand like gas pedals, all those things. You don't have to use these tools only with certain patients.
Right.
If you have the ability and you have the time, why not just assess them as thoroughly as you possibly can?
Yeah. And we always tell, our EMT students, practice a lot. Practice at what is normal, so that when you are presented with that abnormality, at the very least, you're like, this doesn't sound like the rest of the lungs I've listened to, or their grip strength isn't as equal as what I'm used to, right? So do you necessarily have to diagnose that right away? No, because we don't do that in the field, but that's abnormal. That's an abnormal finding. I'm going to say something. I'm going to remember it, and I'm going to document that appropriately.
Absolutely.
Right. So with that documentation, we have to do that on all patients, depending on where you're working at, local protocols. Your patient care reports might look a little bit different, but they all generally have the same information, right? Their chief complaint, what's going on with them today, any type of history of this, what our findings are, what we see, what patients tell us, and then our assessments, what are we finding and what did we do for it, right? In the proper sense. Make sure that's accurate. That's all I'm saying about that. And then when to speak up, right? So again, that's with our assessments, right? So if you're tasked with performing or a physical assessment, you're working with a partner, right? And you're scanning down this medical patient, and you notice that they do have jugular vein distension. Note that and mention it, right? Because that could be a sign of right-sided heart failure, right? That's one of our paramount signs for blood not getting back to the lungs on the left side from the body, right? We're failing on that right ventricle. Speak up about that. If you're doing lung sounds, it's easy to say my lung sounds were clear, or they sound kind of junky, or maybe it was rails. I don't remember, but that was off. One of the biggest things that I think that we lack on as EMTs is not hearing anything at all, and just assuming that that's a normal finding. That is not, right? So if you're not hearing anything at all when you do lung sounds, speak up. Say, hey, I'm not hearing anything on the right side, on the lower right side. Would you mind take a listen for me? And then another partner can get in there and listen and say, yeah, that's not, I'm not hearing anything either. It's diminished. Why is that diminished? And there's a list of issues, lung issues that could cause that, right? So speak up. You find
that's the big thing for new EMTs, especially, is don't be afraid. Blood pressure, heart rate, everything. If you are struggling with obtaining something, have the confidence and be humble enough to be like, someone else needs to listen.
Yeah.
Because the last thing I want to hear is, hey, blood pressure is 120 over 80. Lungs are equal and clear bilateral. We get in the back of the ambulance. Someone does a reassessment. Blood pressure is now 80 over 62, and we're diminished in all the bases of the lungs. Now, the question becomes, you told me 5 minutes ago everything was great. So this patient is now declining rapidly. Or they were that way in the house 10 minutes ago. Our patient is not declining. Our patient this is the accurate vitals that we now have. So don't be afraid to be like you're saying with the lung sounds. I'm having a really hard time hearing this. Will someone else listen?
Yep.
By all means, that should never be a problem from anybody to be like, yeah, no problem. And then en route back to the station or go back to the station, sit down with them and say, hey, let's work on some obtaining lung sounds and, locations of going front versus the back versus the axillary, like all those kinds of things to improve your skill set.
Yep. Yeah. Yeah. When we're dealing with real patients, it's not the time to just guess, right? Yeah.
Or lie.
Definitely don't lie. Right. So focus exam that goes through a couple different things. We can work on a multitude of different questioning while we're dealing with that. Right. So focus exam is, I have a headache. Okay. I can't really check for your headache, but I can ask you questions about it. Like, how long has it been going on for? Where on your head does it hurt? Can you point to it? Does it go anywhere else? Right? What does it feel like? And have you had that type of stuff before, or this headache before? Right? Lung sounds, same thing. I'm complaining of difficulty breathing. I definitely want to listen to your lungs right now, so that we can get that good baseline. So if we can give you, your rescue inhaler, if we have other treatments we can do, oxygen, definitely, right? If they need it. What does it sound like now, so I can track and see if I'm going to help you or not, right? So complaint oriented, focus on that. And then our sample, right? So signs, symptoms, allergies to medications they're prescribed to, pertinent past medical history. That's the pertinent part, right? Have you had this issue before? And, do you have a history of it? And do you have any other medical diagnoses that would help support what we're seeing right now, right? The last time they ate, and what were they doing when this all started, right? OPQRST is a great one for pain, right? I like to use it for pain. Obviously, our paramount OPQRST, I think, is for chest pain. When did it start? Our onset. Does anything you do make it better or worse? What does it feel like, right? And I always, we want to remember, we want to keep those open-ended questions, right? What does it feel like to you? I don't want to sit there and say, does it feel like a sharp pain? Does it feel like a stabbing pain? Does it feel like somebody's sitting on your chest, right? You're inundating them with a lot of questions in that instance, and they might just say yes so that you stop talking to them, right? But if they're having trouble describe it, then yes, you can say, well, does it feel like a sharp type pain or somebody's sitting on your chest, something like that. But quality, describe to me what that feels like, right? And then the radiation, does it go anywhere else, right? So chest pain, I have left-sided chest pain, and it goes up to my jaw and down my left arm. That's the radiation part, right? But use it in terms where it's simple for a patient to understand. Does that pain that you have, does it go anywhere else, right? The severity, that's that pain scale, 1 to 10, 1 being no pain, 10 being the worst pain you've ever experienced in your life. And then how long has this been going on for? How long have you been dealing with it? And what drove you to want to call 911 now, right? That's kind of an important thing. I can't take it anymore. Okay. Is there anything else on focus exam that we could work on?
No, I think just in general, when you're asking them what's going on today and they say I'm having chest pain, sample and OPQRST are phenomenal. It's not the end, right? You can ask other questions. This is not these are the questions you're going to ask. But I challenge people to, you're going to write a narrative, right? Your narrative is basically a story, and you're writing a story to give the reader what they want to read. Well, the reader could be your QA director, could be your medical director. So when the patient says I'm having chest pain, the questions you can ask is just clarify that, right? I want to know as many descriptions as you can possibly give me. So ask some clarifying questions. That goes for abdominal pain, goes for dizziness, nausea, all those things. If they give you an answer, ask clarifying questions to ensure that you understand as the best of your ability of what they're going through right now and why are they going to the hospital. Now, in some cases, it's going to be they're going to the hospital because they want to. And guess what? That's their right. So maybe your questions aren't nearly as extensive when it's very obvious that no matter what you ask or say or do, they're just going to go to the hospital at the end of this game.
Yep.
But all those things are important of just keep asking questions, keep engaging these people and gaining as much information as you possibly can.
Sure. Yeah. And back to that OPQRST for just a sec. Like I said, it's great for chest pain. It's great for any type of pain, really. We can pick some of those portions out for like a difficulty breathing, right? When did the breathing troubles start? Anything you do make it better? Did you take your rescue inhaler and it got better for a while? Or did you take it and it didn't help? Or, and then the quality, I always like to ask, does it feel like you can take a breath in and you just can't get it out? Or are you having trouble taking a breath and getting it out, right? Or vice versa, right? So that is a great quality type question for difficulty breathing. You'd always ask if there's any pain with respirations, so that kind of focuses in on that radiation aspect. Yeah, it hurts on the right side of my chest, and when I take a deep breath, I do have pain with that. That could tell us a lot. The severity, probably not. A breathing scale of 1 to 10, we don't usually ask that. You can see that, right? If somebody's in severe respiratory distress, you're going to see that. It's not going to be a secret, right? So that, again, going back to our physical exam, how's that breathing patient doing, right? The active listening part. So this is something that, us as providers, especially as new EMTs, you struggle with. Active listening, actually listen to what your patient is telling you, and deciphering what they're saying takes a skill, right? And it takes time to develop that because there's a lot of things that are happening both interior and exterior, right? We always have factors that are going to affect that, right? Interior would be yourself, right? So as we're talking to this patient and we're trying to decide or figure out what's going on, working through our differential diagnosis, while that patient's talking to us, we're always thinking about our next steps, right? If they tell me this, I'm going to do this. If they said this, I'm going to do this. And sometimes that inhibits us to actually stop and listen to what that patient's telling you. Most of the time, when we're dealing with patients, it's not hard to figure out what's going on, right? They're pretty upfront with us most of the time. But, if you stop and actually think and listen to what they're telling you, and they'll tell you what's going on, right? They called us for help. So the active listening part, try and not think about your next steps and just converse with that patient, right? Exterior factors are, you know, our partner getting vital signs, and we're making sure that our partner is doing vital signs correctly and accurately, right? A dog barking in the background, you know, can we put that, you know, little puppy somewhere else so they're not as distracting or not as loud? And that usually doesn't help because they usually bark more. But TVs are always seem to be on, and the volume always seems to be up, right? Let's control that. Let's turn that off or mute it so that we can hear what's going on, right? And then, you know, if you have any other family members or friends around, you know, they're trying to give input as well as necessary. So, you know, trying to really focus on what that patient is telling you and retaining that, right? So we have to retain that for two reasons. One, when we give our handoff, whether it's going to be to a advanced life support provider or we're transporting, we're taking them to the hospital, you have to give that accurate information to the nurse and or the doctor. And we have to retain it for our patient care report, like Shaun was saying, right? Our narratives, like Shaun said, are that book, being very descriptive of what that patient told you is going on, how long it's been going on for, and any other, you know, important information in that, right? And then, of course, what you did for them. But
when active listening, it very much is auditory as well as visual.
yeah,
When you're asking them questions, look at them. When they're answering you, do you notice that they're answering you in 2 to 3 word sentences and then they're stopping and taking a breath? If they don't say anything, bring it up to them. Hey, I noticed when you're answering my questions that you're like, that it's causing you to have some more trouble breathing. Would it be a lot easier if I just asked you some closed-ended yes or no questions to allow you to, like, you know, breathe freely? Or you notice that when your partner asked them a question, they didn't turn their neck, they turned to their body. Like, those are all things if we are the patient care like person, right? We need to be 100% in the room, paying attention, looking, hearing, being able to control the scene. You know, I've had times where the officers got their our radios going because there's 3 other calls going on in your agency. That doesn't matter, right? We're with this patient. So turn your radio down, or if you need to listen to that or deal with whatever, then take a step out of the room. Like, we as EMTs that are in charge of these patients have to be able to control the scene. And again, actively listening is visual just as much as it is auditory.
Yeah. I'm glad you mentioned that breathing aspect, that one of the two word sentences. If you're trying to ask your patient a question and they cannot get out an answer without taking several pauses to breathe, you might just have to stop talking altogether, right? So while we're talking about all this exam stuff and, you know, asking the sample and the OPQRST, and we want to know all the information in the arena of somebody cannot breathe and talk to you at the same time, it's very, very hard to do so. Please just stop talking altogether. Let them work on breathing and you focus on what you can see and what your vital signs are telling you.
And if you put that in your report, no one's going to fault you. Every medical director is going to recognize exactly what you're describing.
Absolutely. Yeah. Does everybody that we talk to and we give patient care report, do they want to hear everything? Absolutely. But if you walk in with that patient in the tripod position, you have them on 15 liters non-rebreather, you know, they have cyanosis around the lips and the nose or the fingernails, or they're showing evidence of poor perfusion, and you say, listen, nurse, doctor, I wanted to get everything I did. But this patient was, you know, their initial oxygen saturation was 65%. We put them on 15 liters of oxygen non-rebreather, and now they're at 82%. This patient is sick. I didn't want to exert them anymore trying to get all these questions. I'm sorry, I don't have it for you, right? The act of talking that you and I do on a normal basis is easy, but it takes effort, right? It takes energy to do so. When somebody cannot breathe due to whatever disease process they have, you know, anaphylactic shock, severe asthma, COPD exacerbation, heart failure, right? Left-sided heart failure, that becomes an extremely strenuous, energy depleting event, and we might hurt them. We might make them worse by trying to get all the information we have or we want to get, right? So yeah, sometimes don't do it. Just let them. And I've done
document
that.
Thoroughly.
I've done that before. You know what? Maybe ask a couple head nod questions, yes or no. But outside of that, we're going to work on you. We're going to help you. And I want you to focus on breathing, because if you stop breathing, we got to
and your vitals can tell you a lot. You'll see it in their blood pressure. You're going to see it in their SpO2. You're going to see it in their heart rate. Like, we don't need, the questions are great, right? I want to build as much of a descriptive book as I can, but a really good description is patient was unable to answer questions due to severe shortness of breath and respiratory distress. That pretty much tells me everything I need to know. I don't need to know. You don't have to describe their tidal volume. You literally said it. I mean, that statement alone gives you a lot of clarifying information on what kind of patient you're dealing with.
Exactly. All right. So bottom line, actively listen.
Actively listen.
All right. So where do we go from here, right? We did our primary patient assessment. We worked through our AVPU. We've done our head-to-toe exam, whether physical or just visual. We've got vital signs, baseline, and maybe trending depending on how long we're on scene for. Where do we go from here, right? So transport decisions, obviously, if somebody calls 911 and they're sick and they want to go to a hospital, then we have to determine where they're going to go, right? And that depends on a number of factors. First and foremost, whatever agency you're working for and your protocols on transport decision making. Usually, that'll be in there as a policy or procedure, right? If you're presented with this, you will go this, right? You'll always go to maybe the closest facility unless there's a reason for it. Say, you have a non cardiac capable facility that's closest, but you are through your assessment, you think your patient's having an active heart attack. You might want to bypass that if time allows and go down to the cardiac capable facility, right? So trauma levels, right? Not every hospital has a trauma designation, or they're, a trauma level 3, right? And you might need a level 2 or level 1 if it's in your area, just depending on what's going on, right? So all of those factors come into effect, right? The last one there, the patient's choice. Yes, patients have a choice of which hospital they want to go to, unless it's something serious, right? So say through your assessment, your patient is presenting as if they're having a cardiac event, and they want to go to a facility because they like it a lot, but that they don't have 24-hour cardiac capable, CPI or imaging or anything else that's going to help them. While we want to take those patients where they want to go, sometimes we have the conversation of, yes, I understand you want to go to this facility. However, they don't have the means of helping you right now with what I think is going on. And if I take you to that facility, it's just going to delay your care. And then you're going to see another ambulance as they transport you down to a facility that is capable of dealing with what's going on, right? So patient choice, yes, always, unless we, through our findings, we deem that they need to go to a different facility, right? So know your capabilities of your agencies or your hospitals around. Maybe you don't have one, right? You have one hospital and that's all you get. And then, fine. And then that's okay too, right? They'll stabilize patient there. And if they need to fly them out, maybe because you're in a rural setting and they need a specialty hospital of sorts, then we can deal with that later. All right, so great review of everything. ABC, CAB, patient assessments, we've gone through it all. So let's try and put it into action to round out this training and see how we do, right? So we're called to a local residence for a 72-year-old female. Her chief complaint is shortness of breath. She has some back pain and she's feeling weak. So with that dispatch information, we want to start focusing or start building our differential diagnosis. What do we think is going on?
Right off the bat, I'm thinking possibly cardiac.
Okay. Yeah. Cardiac, I think, should be up there all the time, right? No matter what, right? Sometimes it's easy to rule out right away, and sometimes it's not. But yeah, cardiac, I think, as well. Shortness of breath, we're always thinking, obviously lungs, right? Does she have, depending on the time of the year, is cold and flu season in effect? Does she have a cold? Does she have pneumonia? Does she have some type of respiratory infection? Does she have some type of COPD? Anything else, right? We're starting to build that differential diagnosis, and our goal with that is to hopefully have a good list when we arrive at the scene, and then we start knocking those off, right?
And a good conversation with your crew of, talk to the EMT and say, hey, we get on scene, because again, this is not uncommon for this to be your dispatch information, right? So telling the EMT, hey, do me a favor when we get on scene, real high priority, blood pressure, SpO2, love to have some lung sounds, a 4 lead at some point. Let's try for an entitled CO2, like give them kind of a goal of what direction, or if you're the EMT, sit there and be thinking en route to this call, what is your goal, right? If you have other EMTs working with you, that's awesome. You can delegate some of those vitals to them while you sit there and get your patient interaction and chief complaint and sample and things along those lines. So don't forget to use your team as well.
Yeah, team. That's the key word there. It's a team. We're a team. Let's work together.
If you have a team,
if you have one, and then you are your team. So I mean, we work through the cardiac, right? We work through the lung stuff. Back pain. It doesn't say where their back pain is. So could this back pain be causing the shortness of breath? Depending, right? I don't know. There's, is this chronic? Is this acute, right? Did she have some type of injury? So we're working on a traumatic call versus a medical call. And then, the weakness, that could be anything, right? All of those things affecting if she's got, a cold, a flu, respiratory infection, that does cause weakness because she's just not feeling well. Or could this be something else, right? So we're walking into this scene with this giant list of possible issues that could be going on with the patient, and we're going to start keeping them or knocking them off, right? Ruling in or ruling out. And at this point, do we need ALS, or should we consider ALS if we don't have that option available in that initial dispatch?
Here's my thought on that. It definitely, I mean, there's a million different agencies all across the country. If you have an agency that ALS is already provided, and that question's easy.
Yes, easy.
If you have an agency where you have to request ALS and they are an ambulance, you could probably justify this, right? Geriatric female complaining of shortness of breath, this could be cardiac. But if you're an agency that the only ALS you have is an ambulance that's an hour away, or it's only by helicopter, in this case, I don't think you really need ALS, right? So I think depending on those varying situations, I think you could justify it.
Yeah.
I would pose that question to the listener of just being like, how does your ALS response work? And put yourself in this situation. If you know how your ALS system works, if you even have that. So would you involve ALS at this point?
Yeah. And with all of our case studies that we bring up, that is to, yes, you get to hear us talk and work through it, but I really want you as agencies or you as groups or you as that sole provider to stop and actually work through this yourself. Think about where you're at and what options you have.
Hit that pause button.
Hit the pause button.
So you're not listening to us like give away what's next or whatever.
Yeah, because we're going to do that. That's
why
we're here. But yeah, stop, pause, talk through it. Maybe there's something on your differential diagnosis that you folks think of that we didn't, right? Add to it. All right. So we show up. Husband meets us at the door. We walk in, then the wife is found sitting on the couch. So start working through our general assessment, right? And the alertness, she acknowledges your presence. So on the AVPU, she is at least alert enough to track us as we walk in. So we can determine that if a patient is sitting up and talking to us, then they have some type of circulatory function.
So we're using ABC.
Using the ABCs. We don't have to go right to the CAB, and we don't see any obvious bleeding, so we don't have to go XABC, right? So, she's sitting up. She has some type of circulatory function. Doesn't mean that's necessarily good. We don't know at this point because we haven't started putting our hands on the patient. But, and we walk in. we see her and then we're automatically assessing her airway, breathing, and circulatory signs, right? So while she's inhaling and exhaling, do we notice anything apparent sticking out of her mouth that could be a foreign body object or foreign body that is, obstructing her airway? Her breathing in this case, when we have shortness of breath calls, it is really important that we pay attention to the rate, the quality, and what we hear, right? So rate, if she's compensating for some type of medical condition underlying, then she could be breathing fast, right? Fast. Is it shallow? Does it appear that she's really struggling to breathe? Is she in that tripod position? And then with that breathing too, can we hear anything from across the room without even putting a stethoscope on it at all, right? If you have a good patient with, not a good patient, but if you have a patient with a severe asthma attack or anaphylactic shock or anaphylactic reaction, then you will be able to hear that wheezing, that expiratory wheezing from across the room, right? It is not something that you just need a stethoscope for. Yes, we want to follow up with the stethoscope and see if, where it's at, what side, if one or both sides, upper or lower. But the fact that those bronchi are restricted and she is actually having to work against trying to get air out, you're going to hear that from across the room, right? Another one I see a lot is with rales. So rales is pulmonary edema, right? So that's usually associated with some type of left-sided heart failure, whether acute or chronic, or she has an exacerbation, right? So as our left ventricle cannot pump effectively blood out to the rest of the body to oxygenate the body and then come back around in that circle, then we'll start to see a backup, right? So just as earlier we were talking about right-sided heart failure and seeing the JVD and the pitting edema because that's blood returning from the body and going to the lungs, the left side is just the opposite, right? I can't pump that oxygenated blood to the rest of the body. So then I'll start to present with difficulty breathing and that rales sound, the sound of a plasma shift in the alveolar sacs. Essentially, the patient is starting to drown themselves, right? So, and those patients with pulmonary edema, I have heard them from across the room, right? Again, we're following up with our stethoscope, listening to good lung sounds, but you can usually hear if you have a good, again, I say kid, it's not good. A patient presenting with some significant pulmonary edema, you're going to hear that.
I think any audible lung sounds, your patient's automatically sick.
Oh, yeah, for sure.
You walk in the door and you can hear them breathing. Breathing should be effortless and silent without a stethoscope. So if it's not either one of those, you sick automatically. I mean, and then we can, you can determine not sick later if you needed to.
Right. Yep. So, so her breathing is labored. She's obviously working to try and breathe, but she does have normal tidal volume, right? So a good 1 to 2 second inhalation, followed by small pause, and then a good 1 to 2 second exhalation, right? On a basic level, that is a good tidal volume breath. Circulatory wise, she's pale, so that's evidence of lack of perfusion already. She does have some clammy skin, so it's not necessarily she's profusely sweating, but it is a little moist in a warm, dry environment. And then you feel radial pulse and it feels thready. Okay, so that's positive findings for some poor circulatory function. And so now, if we haven't already called for ALS, or we haven't already thought about launching the helicopter, if that's already our means, maybe we want to do that now. And then transport decision, do we want to stay on scene forever and hang out, or do we want to think about getting a good baseline set of vitals and moving towards our transport so that we can start getting her to the facility that she needs to be at? Okay, so vital signs, you get a manual blood pressure of 86/54.
How did you know it was going to be hypotensive?
How did I know?
Yeah.
Well,
besides the fact that you wrote it.
I wrote it.
But that thready pulse is a real good giveaway.
Yeah.
Right?
So,
that's kind of the, if you've been an EMT for a long time, we were taught the radial pulse is a blood pressure of, at least,
depending on the book,
100. And I think brachial was 80. And so whatever it was, I don't remember because I had
depending on the book, there's a
if
range.
you check a radial pulse and you have one, if it's thready, I'm already thinking that they're going to be hypotensive.
Yep.
So those are just like cheater ways. They're not fact. They're not 100% proven, but they're ways of being like, oh, when I take a blood pressure, if I have a thready radial pulse and I ask someone to take a blood pressure for me and they come back with 120/80, that should raise a little red flag going, can we just take a manual blood pressure and just make sure that's, because that doesn't really make sense with this whole picture.
You stole my talking point. Thank you for that.
Sorry.
So, so circulatory presentation wise, our signs that we're seeing, we think we anticipate to be hypotensive. If we have 210/126, that's something maybe, but let's follow it up with a manual blood pressure, right? So, but because you're such great EMTs and we talk about manual blood pressures, you did it and that's what you got. That is a positive finding, and that supports what we are seeing externally, right? She has a pulse of 68, oxygen sats of 94% on room air. She has a blood glucose because you assessed that and it's 264, and then you took a temperature, it's 97.6. Now, outside of the hypotension, there's another vital sign that we have that is concerning. Shaun?
Put me on the spot, huh?
I did put you on the spot.
Pulse rate.
Pulse rate. Oh my gosh. You got it right. Yeah. So when we're thinking about shock states, right? And we have the compensating shock, decompensating shock, and irreversible shock. Basically, we're not going to end well, right? We would think that, she's alert. She watched us walk in. We haven't really conversed with her too much, but we would suspect that with a high or with a low blood pressure, then we would have an elevated pulse rate, right? In this instance, we don't, and that is a positive finding. And we need to start thinking about then why that is, right? Is she
Absolutely.
in decompensated shock and we're getting ready to, be more aggressive with this patient, or is there something else that may be contributing to or stopping her from having a high pulse rate? So again, this would be a great time to pause this and have a conversation in the group, right? Start to think about what could be causing that. Why is her pulse rate not presenting as we have learned for compensated shock, where she should be tachycardic? Okay. And then oxygen saturation.
Are you going to tell him?
We'll tell him.
Oh, okay.
Yeah,
I was going to guess. I haven't even seen the next slide, so I was just going to guess.
Yeah, no. We'll talk about it.
Okay.
I will tell you the answer.
Okay. And everyone's yelling at their screen right now.
I can see the comments right now.
Yeah.
You didn't tell us. I'll tell you. Blood glucose 264. We haven't asked her any sample questions yet, so maybe she's diabetic. Another thing that can cause hyperglycemia is what we call stress hyperglycemia. So when we're not feeling well, or we're in that kind of like fight or flight syndrome, and we're dumping a bunch of stuff to try and maintain homeostasis, but our body is like, hey, we're getting ready to fight, or we need to run. This occurs with illnesses, right? So we'll start to dump a bunch of glucose in our bloodstream to try and compensate the energy expenditure that our cells or tissues or organs are going to need, right? So that could be a cause of it. So it is noteworthy, right? Because that's outside of our normal range. So,
well, and then picking on the EMT student, right? Maybe who says, well, wait a second, my textbook says anything over 160 is hyperglycemia.
Yeah.
Yes. 264 is not good for you.
No.
It doesn't mean that is the problem. Just because it's abnormal does not mean that's what's causing all of these problems. We have to understand that truly, I have to be cautious when I say this, the most life-threatening sugar issue you will see is hypoglycemia. Too low is a problem right now.
Yep.
Too high is a problem, just maybe not right now. If it stays 264 for the next 3 weeks, 3 months, 3 years, neuropathy, nerve damage, tissue damage, absolutely. But that's not, don't look at that and go, that's something we have to correct. First off, you can't correct hyperglycemia in the field. So almost kind of take that out of your brain of like, it's definitely something to mention to the next provider.
Yeah.
But that is not, it's an indication something is wrong, but that's not something you should be taking focus on.
Yep.
Because I think
exactly
newer EMTs, especially, we memorize parameters and ranges.
Yeah.
Right. And then when it's out of that range, all of a sudden that's what you're concentrated on. And again, to the contrary, what's interesting is you look at that pulse rate of 68, almost in your brain, you go, well, that's normal.
Right.
That falls within normal. So guess what? I shouldn't have to look at that.
Yeah.
Time out. No, you should. Right. Because you have a hypotensive blood pressure and a regular pulse rate, that disconnect right there automatically is like, wait a second, that's a red flag.
Yeah. I threw in a lot of good talking points.
You did a really good job with this one. I'm surprised.
I don't remember doing it, but hey, yeah. So again, maybe pause this and talk about, why could her blood sugar be high outside of what we just discussed? Is there anything else that could be causing that? So our head to toe physical exam, again, we don't have to be physical with everything, but we need to be visualizing everything.
Hey, what's cephalic?
Cephalic. So normal cephalic, that just means there's no obvious swelling or deformities to her face, right? So fancy medical term. Or head.
Yeah.
Don't have to use it.
Cephalic delivery, if you ever see it, is head first delivery of a baby.
Yep. Perfect. Yeah, just think about OB stuff.
Yeah.
Her eyes, you use a pen light. They're 4 millimeters in reactive. So every time you shine that light in, they do constrict appropriately. So that's fantastic. You look down at her neck, you have noted jugular vein distension as she's sitting up, right? So again, that's a positive finding and could be.
And you had mentioned that's more likely right-sided heart failure.
Yep.
I'm only bringing that up because when you say the next thing, which is rails in the lungs. Wait a second, that's left-sided heart failure.
Yeah.
So what do we have in this case?
Well,
you have heart failure.
Both. Either side is bad. Both together, probably not.
It's really bad.
Yeah. So you do have noted jugular vein distension. So we're thinking right-sided heart failure issues. Fluid retention maybe caused by something else. I don't know. And then we have rails. So that evidence of pulmonary edema in her lungs down at the bases. Again, like Shaun said, that's left-sided. So we have both together. We could have a very, very sick patient on our hands, which given the vital signs in her patient presentation, I would venture to guess we are. Yeah. So our abdomen, soft. It doesn't look distended at all, right? So palpate that real quick, looking for any rigidity because again, we have hypotension. Could this be cardiac driven or could she have a bleed of sorts, right? GI bleeds, any bleeding in the abdomen, we want to palpate that, make sure we don't have any rigid, distended, tender abdomen. She does not. Her legs, we look down at the legs. We note that they appear swollen. We press on them and we get +2 or 2+ pitting edema. All that means is you push in her skin and it stays there, right? So we have a gradient of pitting edema. 0 being you push in and it goes right back to normal or swollen. +1, you push in and it sits, but it takes some time to go back to where it was, get that fluid back in. And then +2 pitting edema, you push in there and it stays. It's indented, right? That is just all it means she's retaining fluids or she's having a fluid shift down and gravity pulled it. Again, that's with that JVD, we should be highly suspicious of right-sided heart failure.
Yeah, quick mention, if this patient is bedridden, right, or maybe spends a lot of time in a recliner with their feet up, you're not going to see the pedal edema. You'll be looking for that like in the sacral region or wherever gravity is going to pull that.
Yep.
So don't get lost in this. This patient with pedal edema would need to be somewhat ambulatory, or at least gravity needs to have their feet lower than the rest of their body.
Yeah.
So be looking for where gravity is going to pull that fluid, to be looking in those extremities and outside of lungs and JVD.
Yep. Outstanding. All right. So our focus exam, obviously we're going to listen to those lung sounds. Maybe we heard her breathing from across the room. We could kind of hear evidence of what sounded like rails or something real wet. We're going to listen to that, of course. She has some pain in the back, so we want to palpate that. Is there anything that we can do to reproduce that? And ask her to point to where that pain is, right? And when you do, she kind of points to her shoulder blade. Right in between her shoulder blades is where she's feeling it the most. So we're moving on with our sample. She doesn't have any drug allergies that you know of. Her medications are metformin, atorvastatin, and metoprolol. Good. So pharmacology, Shaun figured it out, right? So these medications now, as EMT providers, do I expect you to know all the medications that are available on the market today? No. I'll tell you this, I don't, because it seems that like more and more medications are coming out.
It's like every time you go to a patient, there's a new med you've never heard of before.
Yeah. The great thing about being able to converse with somebody and not knowing a medication or what it's for, ask them, hey, what do you take that for? Metformin. I that sounds familiar, but I don't remember. What do you take it for? I take that for my diabetes. Okay. So then we can go down to, like, I don't have to ask her if she has any medical history. She's taken metformin. She has diagnosed diabetes, right? She's taking atorvastatin. That's statin. Anything statin has to do with high cholesterol. So that's that fancy term down there, hyperlipidemia. And then she's taking the metoprolol. The Olol is a beta blocker, right? So that prevents heart rate from increasing past a certain point in most instances, right? So that takes out our compensatory mechanism, right? So we look back at her vital signs, her pulse is 68. Well, that's about the rate where metoprolol will allow you to go, right? It doesn't allow you to compensate for anything. So in this instance, that's important to note, because we know that her heart rate is not going to be able to increase. Her squeeze might not be able to increase as effectively to get more to bring that blood pressure up. And that would be that medication or all those beta blockers, calcium channel blockers, whatever. We're not going to turn this into a pharmacology class, but those will always inhibit a compensatory mechanism. So that is why getting our medications list is extremely important, especially, whether it's medical call or a trauma call, right? So she has hypertension, HTN. No. So with this too, and pause and talk about this, but we start to look at high risk cardiac patients in this instance, right? So she's, she's over the age of 55, which is one aspect of high risk cardiac. Family history of, so a good question would be, do you have any family history of heart disease? Just keep it at that. And they'll say, yeah, my dad died when he was 60 or whatever, or my brother had a heart attack. That's one of those as well. And we start to look at these disease process. So diabetes, high cholesterol, high blood pressure, smoker. So we want to ask that, does she smoke? Does it smell like smoke in the house? We see evidence of any cigarettes lying around. Those are all contributing factors. Now, she doesn't have any, at this point, diagnosed cardiac disease. She has high blood pressure, which she's controlled with medications. But, so start to look at that as well. And that can help us narrow our differential. Now, can we knock everything out completely except for a cardiac event? No, but we keep cardiac number one, and maybe we should in this instance, right? Definitely should in this instance. So great. So then we asked, when she ate last. She ate last night, and this is, I don't know, this morning time.
Yeah.
So she said she doesn't really have any appetite today. And then events leading to is always important. We look at cardiac events as, is this exercise induced or activity induced, or did it just come up out of the blue, right? And she said she woke up this morning with the evidence of back pain and feeling short of breath and not very strong, right? So then we can follow on with our OPQRST, right? So working through this, nothing makes it better or worse. It started this morning. She was complaining of back pain, but as you start to question that more and more, where is it? Does it go anywhere else? And she says, yeah, it kind of feels a little heavy in my chest as well, but that pain in my back is what's bothering me the most. And a quick pause on that, cardiac patients, female with these type of disease process, diabetes especially, they don't they may not perceive pain in the same way as our classic signs and symptoms of left-sided chest pain radiating to our arm and up into our neck, right? And I say most of the time now, if somebody says that, then that's an abnormality, right? Any other pain or medical complaint is probably evidence of a cardiac event more so than the classic signs. So talking about that radiation, and it goes chest to back, and she says it's about a 6 out of 10, right? So she's been up for a couple hours now trying to deal with this, and it's not getting better. Maybe it's getting a little bit worse. So she decided to call 911, which is probably a good thing. All right. So depending on where you're looking at or where you're working, protocol dependent, you can obtain 3 leads and 12 leads for your ALS counterparts if they're going to show up, which is a good thing to do, right? So on our 3 lead 2 there, that looks normal, right? So this is where, we don't talk about 12 lead stuff or monitor stuff a lot in the basic realm. Some agencies are probably better than at it than others, and we will hold a more of a 12 lead class, the basics of interpreting rhythms. But so basically what I was trying to show here is that when we put a patient on a 3 lead, right, we attach those 4 electrodes and we get a basic reading. That is a non-diagnostic reading, right? We cannot rule in or rule out heart attacks based on that. We have to get that full picture, right? So because you're great EMTs and your agency allows and you have the capabilities, you do a 12 lead for your ALS because you said this patient's sick. They need potentially a medic or, our helicopter nurses, and we need to get this patient to the hospital fast. And you do that 12 lead for that patient. Now, again, you don't have to know how to diagnose or interpret this 12 lead. One of the great things is most of the monitors out there will tell you if they think that something is wrong. And with that, this is a LifePak 15. Again, we're not sponsored by anybody, but it'll come up with a couple asterisks and say acute MI suspected, right? So acute myocardial infarction is suspected, right? Now, as EMT providers, we can't say, yeah, I agree with that. But you just have it, right? So hand it to your ALS person, say, hey, we got a good, clean 12 lead for you, and it looks like this. I don't know what it says, but it doesn't look good. And it says it at the top.
When especially if they're, longer response time to you, you can mention, hey, we obtained a 12 lead, give a patient update. We got a 70-year-old female complaining of shortness of breath, pale, cool, diaphoretic. We obtained a 12 lead, and 12 lead says acute MI suspected.
Yeah.
And maybe they'll give you some pre-arrival instructions, or you're just notifying them that things are pretty critical here on scene.
Our assessment thus far is pointing to a pretty sick patient, probable now with a cardiac event, and please hurry and help us. All right. So transport decision, right? We know, do we have a facility close that can do cardiac stuff like, PCI capabilities or, the cath lab, which she might need. And how far is that? If we haven't already, do we need to call for a helicopter to get that person to the appropriate facility? Or can we get there faster, running within our protocol of lights and sirens? Hopefully you've asked for help already from ALS because you were presented with a pretty sick patient. Is there anything else that we need to do or determine for this patient we were presented with?
To me, aspirin's a must.
Yep.
Right? No allergy, not already taking any other sort of, aspirin-based medication, no contraindications in this case. So 324 milligrams, baby aspirin, go ahead, chew it up. Nitroglycerin at the EMT level is not applicable because she's not prescribed it.
Yep.
Right now, if you had an age, I don't think any agencies, I don't think national allows EMTs to give it unless it's prescribed. But aspirin, I think, would be the biggest thing in this case.
Yeah.
The challenge I wanted to put to all EMTs is we're all in this job to help people, right? if you forgot to ask a question in your assessment, your medical director is unlikely to see that in your report and call you and say, hey, you forgot to ask OPQRST. But if you forgot to give a medication that is in your scope of practice and you didn't give it in that documentation, when the medical director reviews it and sees your patient was conscious but had a glucose of 40 and you never give oral glucose, or in this case, you have a pretty well-known cardiac patient and you never gave aspirin, like the medical director could call you and say, hey, you had all the things pointing towards giving one of the very few medications that National gives you. You should know those.
Yep.
So at the end of this lecture, pull your protocols, know your indications, your contraindications, your dose, your route, what it does, why it works, how you give it, how is it packaged, all the information. We need to be like pharmaceutically intelligent, because those are the few things that we can do. Aspirin could save this lady's life. And it's not even right now, right? It could save this lady's life in the next 72 hours, right? Oral glucose or glucagon in some cases could save someone's life. Albuterol can save someone's life. Those are the things that we should be great at asking questions. We also need to know our medications and protocols.
Yeah, outstanding. Yeah, and in this case, yes, we have the aspirin. We do give it. Quick review of aspirin is a platelet aggregator, right?
Not a blood thinner.
Not a blood thinner, right? So it kind of coats itself on platelets and prevents them from doing their job, essentially, right? And in this instance, if we're thinking of a heart attack, we have a plaque buildup and blockage. And if we allow platelets to do their job, they don't know, if this is other platelets they're attaching to, or they just think there's an injury and they need to stop it, right? Well, in this instance, we stop blood flow in the coronary arteries, and we could kill our patient, right? The patient could kill himself essentially with not trying to, right? So that in ACS events, when we have a myocardial infarction, aspirin is the medication that we must give that can help a patient later on, like Shaun said. So good. Review your protocols. That's your homework. Anything else?
I don't think so.
No, let's get her to the hospital and where she needs to go. Okay. So, so with our conclusion, a majority of our calls that we probably run on are medical based, right? Depending on where you're at, that's 85+% of every call that we go on, some type of medical complaint. So the idea that we can be mediocre at a good medical assessment, it doesn't need to be there. We need to be great at this, right? And like we talked about in the beginning, talking to your patient, having a conversation with your patient is how we get there, right? Don't try and sound smart and use all the medical terminology in the world. I tried it one time and I failed at it, and so I don't do that. And especially when we're talking to the patients, like they might not understand what you're saying for the most part. So this is just simple conversations. How are you? What's going on today? How can we help? All that stuff. Always strive to be better, right? If you're not seeing a lot of patients due to, where you're at in the country or, rural medicine or wherever, study those sheets that are available, right? Those are good starting points. And those are just to help you work on your own systematic approach. And that systematic approach that you've developed, if you've developed it already, do it each and every time and don't stray from it, right? Make it second nature. And that'll help you out years and years from now. Don't forget to actively listen, right? That is truly a skill that we need to practice and practice often, right? Don't let the distractors keep you from listening or paying attention to what your patient's telling you. Because like we talked, they're either going to tell you it, or body language is huge in this, like we talked about earlier. And then again, at the bottom, use the tool.
Slide that in there, don't you?
I heard it somewhere. Use the tool. Don't be the tool. Don't rely on those.
Don't be a tool.
Yeah.
You are the tool.
The tool. Yeah. Anyways.
Nice work on that one.
Hey, thanks for checking out another episode of EMSconnect On Shift. Please subscribe, review, and rate our podcast on your favorite platforms. Those ratings really help our podcast grow and reach new listeners. Also, make sure to like and follow our social media sites by searching EMSconnect on Facebook, Instagram, and YouTube. Thanks for getting educated with EMSconnect.